I really thank Professor Mishra to invite me to this institution. I understand it's a conglomeration of a lot of different specialties, and out of which the medical colleges, dental or healthcare areas, there are quite a few institutions. Today, what I'll try to talk to you about what is happening now in the whole medical science and healthcare practices. Now, you have to realize that there is a tremendous progress in all branches of science. And as you can see now in the space science, we are doing many things we have never imagined. And then similarly, there are large number of areas like the basic physics, chemistry, biology, computational science, artificial intelligence. Now what happened? All these things are coming together for medical practices, because the health is the most important single factor in the world, and which is serving the mankind, and which is obviously serving for our progress in the different areas. So unless we have a good health, we can't do anything. So that's why recently all these research outcome which is coming, say for example space imagery, the same technology we are now using for image analysis, and which is being used for the diagnostic pathology. Basically there is an AI interface where the normal microscopic appearance of the tissue and deviation from the normal can be picked up automatically, and then it can be those abnormal areas can be shown to the pathologist, but if it is a routine one, it may not be shown to the pathologist also. The diagnosis can come out. And that I gave you one example. And there are several these kind of things where what is happening, the engineering research, the mathematical modeling research, synthetic biology research, everything is coming together and finally developing interventions, either diagnostic intervention or the therapeutic intervention, which is coming to the doctors for health application. So these technologies, which are new technologies being developed through this interdisciplinary research, these we talk together as emerging technology. Now in the emerging technology, you must have heard about the nanotechnology based medical practice, that is nanomedicine, that is one. Then there is the molecular targeted medicine, which we call the precision medicine or molecular medicine. Now today, not going to the so much of details, which may, difficult for you to, also not very exciting to you. What I'll try to do, I'll just give very simplified manner the concepts of these things, that how things are progressing really fast. The problem is happening what? When we are actually students, like long back in the 80s, late 70s or 80s, then what happened when we read these, your same medical books, your pharma books or whatever, the amount of knowledge that time and application was quite restricted. We never used to imagine the things which is being routinely being practiced nowadays. So that's why you can see that over these, say, 30-40 years, there is a huge transformation of these new technology development for health applications. Now the pace is much faster, because everybody is doing a lot of research, and that's why things are coming much faster. The greatest example is the vaccine development for COVID-19. Normally, one vaccine development, it takes almost, with the clinical trial, 9 to 12 years before it can come into the market. But for COVID-19, it took 9 months to 12 months from this initial planning stage, development stage, rapid clinical trial, and early approval to come to the I think, application vaccination for this patient. Now, if you see how 9 years or 12 years, the whole protocol, we could compress into 12 months. Nothing is bypassed. Everything is same. The same kind of validations have been applied. But then, difference is that here we have used a lot of data analytics, a lot of computational modeling. If what we are seeing, injecting something to the animal, now it is possible with system biology computation. You can mimic, simulate what you may expect to happen in the animal. And then that will reduce your time for number of animal groups to be done. You can exclude by computational modeling some of these groups which may not be necessary, and zero down to only most essential groups of preclinical trials. So similarly, in clinical trial also, similar things can happen. So that means nowadays the whole protocol of things are changing very, very fast. So that I gave you just one example. I think let us go to today actually I was planning to only focus in the diagnostic part, and but then essentially the concept will be applicable to therapy also, because whenever you are trying to diagnose something, a particular disease, you have to be pretty sure or very specific what is your target event on the basis of which you are diagnosing a particular disease. The evolution of any disease depends upon certain alteration of a structural component inside our body, and when that structural component is being affected, then also there is a functional correlation. So it may be restricted to a particular organ, but then the whole area, when we reach the diagnosis, basically you can classify into 3 categories. Patient come with some symptoms, then we take the history, and then after that clinical examinations are done, and then obviously we arrive at a provisional clinical diagnosis, and then comes the investigations. So we, depending upon our clinical diagnosis and the differential diagnosis, what other things can happen with similar kind of symptoms and clinical signs, then we advise the investigation. In the investigation, obviously, we go for different kind of biochemical analysis. We take the blood, any other body fluid, we send for different kind of estimation, like blood glucose, serum creatinine, liver function, renal function, and all those things, hemoglobin, parameters of blood. And then comes the pathology. If we suspect in a particular organ-specific disease, sometimes we try to sample that. Now either we can do an aspiration cytology, we aspirate out some cells from these so-called the disease area and try to see what kind of abnormality is there, or even we can get a tissue sample. Now I'll explain to it that the mere morphological appearance by some staining is changing very fast. When we are looking at a particular tissue or cell, we are trying to understand inside the tissue and cell what particular substructure is getting affected or what abnormality is happening, not only by visual thing, which is the structural alteration, but also the functional component. Maybe there is some enzyme deficiency, or there may be overexpression of some protein, or there may be abnormal expression of the receptors. So earlier, morphologically, we can't pick that up, but we can use different techniques on that to actually get more information from that cell or tissue. I'll come to that later. Then comes the microbiology. Conventional microbiology, what you are reading nowadays, down the line in 5 years, everything is going to change. Because no more we will be doing culture to diagnose a particular infection, or no more we will be doing these antimicrobial resistance by the disk diffusion assay. These are all going to happen with the molecular analysis or the sequencing of these, the genetic sequencing of these organisms. Because as you know, for viral diagnosis, I'll give you example. See, how do you do the viral diagnosis? Either you take a blood serum and look for antibody. IgM antibody, if you get, that's a very acute infection indicate. But that's a very indirect kind of proof. The correct proof, you can go for viral antigen. That can be done by ELISA. But many times that is sometimes not possible. So we go for particular DNA sequence specific detection. So there we use these molecular techniques of the PCR. And if you want to do the viral copy or amount of number of virus load inside the body, then you have to do the quantitative PCR. So nowadays what is happening, more and more we are going for this kind of molecular analysis. See, antimicrobial resistance is becoming a huge problem in microbiology, in day-to-day infection. For antimicrobial resistance nowadays, we are also going for mainly sequence-based data generation. So, because it's not possible sometimes to do culture of the organisms, particularly in many patients because of different logistics problem. But even if your particular bacterial count is very low, if you try to do the target sequencing of those bacteria, looking for antimicrobial resistance gene or ARGs, then you can identify that. Though this technique yet to come in routine clinical practice, but I think it is going to come very soon because we are becoming very strong in DNA sequencing. The sequencers are becoming much smaller, much easier to do because bacterial genes have got very small number of DNA copies in comparison to, say, human genome. So theoretically it is possible, technicalities will be sorted out soon. So that's why if you see the way we are reading our books now, the way we are getting trained, there is a rapid change in practice. So this gap is really becoming bigger and bigger. So the challenge is that when we teach you medicine, how we also make you aware how quickly things are coming up, so that down the line when you will be young doctors or pharmacists or dentists, there are a lot of things which is going to come which you are not reading now. But then what we can do, we can make you aware of things to come so that you can keep your eyes and ear open and learn those things and follow up those things which is going to come into the market or health intervention in near future. That's a very important paradigm of developing our human capacity, developing you as experts who are beneficial for the society in future. That's very important. So what you are learning, it's not a theoretical issue. You are learning to do certain jobs. As the job profile is changing, your medical intervention technologies are changing, so you have to prepare yourself to make it competent to do that particular job. I'll give you just one specific example. Oncology practice is changing very fast, both in the diagnostic area and also in the therapeutic area. In diagnostic area, you are now coming up with this proton-based imaging system. One or two are there. I think it will be, technology is becoming easier, so more and more that kind of imaging will come. This is a much superior technology than the MRI. And then also the functional MRIs are coming up. The classical example is prostate cancer and its metastatic detection. What we are doing, see, there are the iron oxide nanoparticle which can be easily picked up by the MRI system. So you can tag that iron oxide nanoparticle with anti-prostate specific antigen antibody. If you inject them in the vein, then where the tissue has got this PSA, prostate specific antigen, it will go and bind over there. So you have either residual tumor, reactivation of the tumor at the site itself, or you have got metastasis. Specifically you can pick up by this functional MRI. So that means you don't need to look for, this is a very sensitive imaging system and even if it's a small, see, several thousand of these cancer cells, when a very small micrometastasis has happened, which is difficult to detect by CT and MRI, if you do a functional MRI with this kind of antibody tagged nanoparticle, it is possible to pick them up. Now this is not theoretical. The urology practice, functional MRI, I think in several centers has started. Only thing is that you can ask me, then pathology practice will stop or not. It's not like that. You know, the final diagnosis is still, fortunately, with the pathologist. But the way things are going up, going down, so basically the pathologists have to change the practice modality. You understand? So what I am talking today, I think maybe in 5 to 10 years, many of these things you will be seeing by yourself. So that is my central theme of this talk. So I came to the imaging. The imaging is a technology which is now beyond radiology. No more is the only radiation stimulus being used for imaging. I give you one example of magnetic resonance imaging, breast imaging. So that is a different technology. Now we are using extensively thermal based technology and also the in vivo fluorescence based imaging. There are fluorescent molecules which can traverse around 12 centimeters of tissue. Normally fluorescence based imaging problem is that it gets by the mass by the body tissue, body mass. So the fluorescence signal you cannot pick up. But then the technology is coming up where the different kind of thing you can tag and inject in the vein with fluorescent molecule tag, and then you can detect it from outside. Advantage would be these are all in vivo imaging, and it can follow up your regression of the tumor and also some of these area specialized infection regression or many kind of functional thing you can do if we can develop this kind of fluorescence based imaging. And the molecule, fluorescence molecule, we are using, they have got very specific wavelength which doesn't interact with the autofluorescence of the tissue inside the body. So that means the imaging technology is coming up in a big way where the conventional radiologist has to also learn these things. And we are talking of now at the molecular imaging level. So molecular event which is happening, say PET scan also, if you, I think many of you know, that is also a component of functional imaging where the metabolic alteration in a tissue can be picked up by the PET scan. So now, how the things are progressing. I gave you 2 or 3 examples. Stethoscope, everybody, I think all the MBBS students also know, you will be using, all the postgraduate you are using day in and day out. Now the electronic stethoscope is being introduced, even this is introduced by Littman. What happened in this, there is a electronic, the signal picking device embedded with the stethoscope, and they have a discriminatory capability. So the signal can come into your mobile, and then also there are the noise, selection out of the noise, and specific signal amplification technology is there. And now these companies are trying to inbuild the AI where it will give you suggestion. Now you have to realize one thing, all these technologies which are coming up, there is a question of its 100% accuracy. And whenever we are using AI, so there is a problem of gold standard comparison. Unless you are sure about gold standard comparison, and we never know that whether AI is overdoing things or underdoing things. So that means standard clinical examination is our gold standard. So you have to do or make yourself very, very strong in standard clinical examination. See what is happening over the years. If you see the American medical training system, the doctors are becoming very poor in their ability to do clinical examination. So what is the result of that? Large number of investigation is being done. But if your clinical examination capability and clinical understanding capability is strong, you can narrow down and your analysis wise, what is the specific disease or organ specific disease the patient have, and then you can have the first line of investigation. If you are not satisfied, then you can go for second line of investigation. Like that. That will make life of the patient simple. Quickly you can arrive at a diagnosis, and also this will be cost effective. US, which is otherwise has got a pretty huge economy. So they are now looking for, I think I am quoting one of the New York Times editorial, they pointed out India is one of the countries which is contributing a lot of experts or doctors who are strong in their clinical examination capability and clinical diagnosis. And that's why they should be much more cost effective in managing any patient if they have compared with the all other institutions which are sending doctors to USA, America. So that's why my point is that those of you who are studying MBBS or doing post-graduation in medicine, even if I am talking about all these advancements, but your central theme of clinical examination is extremely important, because at the end you have to do clinico-pathological correlation when you can definitely do a specific medical intervention. So I'll give you another example. There are many. So there are nowadays endoscopy capsule, camera-based capsule is available. So these are capsules which can be swallowed and inbuilt with the camera with the Wi-Fi capability. So when it traverses through the different parts of these gastrointestinal tract, it emits the images, and these images are recorded in a computer. So then the next day one can analyze the whole GI tract abnormalities. So that is a reality that is being done and commercially available. Now similarly, this is a technology which is being incubated in our incubator in AIIMS, where the fetal heart sound monitoring is routinely done for the progression of these last phase of the pregnancy. Now these guys have developed a sensor which can be put on the mother's abdomen, where it can record the uterine contraction as well as fetal heart sound. Now both these can be transmitted to a remote computer, and so in all difficult labor cases, these cases can be real-time monitored and not going to the bedside every now and then and checking the fetal heart sound and the uterine contraction, but it can be monitored in a central console. So we exactly know that what is the condition or progression of these the labor. So these kind of things are basically clinical examination assistive devices. So there is a lot of development is happening nowadays in these. So obviously the practice line is getting changed. So that means a doctor, another interesting dichotomy I am telling you. When we are students, I feel today, mathematics is not needed to become a doctor. But I personally feel it's no longer like that. If you want to become a neurosurgeon or pediatric surgeon, where precision symbiotic knife, these are basically software-based laser system controlled knife is being used, where you wear a gloves with sensor on the tip. You don't hold any knife, but your movement of the finger directs this laser to act as a knife at the site of operation. For that, you need to understand the computational dynamics of that operative procedure. So, if you don't know anything of your mathematics or very weak in mathematics, the picking up those kind of cues become little difficult, which is the practical problem we are facing with many of these experts. So that means for the future physician, one has to know physics, chemistry, mathematics, biology, all these well. You can't leave one thing and then try to think of excelling in this advanced the medical practice which is going to come. To make you think a little bit of deeper, as I have explained to you that what we are going for, the advances in laboratory diagnosis or any kind of diagnosis, what is happening, we are looking for a biomarker. Now biomarker particularly specific to a disease. Now this biomarker, if I define a biological molecule detected in the body fluid, it may be in a tissue or cells or even the expiratory air. Even you could exhaled air, the molecules can be detected to know that what is the conditions of your lung. Routine practice, FeNO system, that is the expiratory nitric oxide being measured in asthma patients to understand whether there is a significant inflammation is going on with this asthma or not. the patient or not. And that is help us a lot to use judicial use of the antibiotic and steroids. So those kind of things are coming up now. So these are called electronic nose. And even in certain kind of cancer now, we realize that volatile lung cancers, volatile organic compound in the expiratory breath is diagnosed. So these technologies are coming up. And no more we have to really poke our needle and get the tissue and diagnose it. In screening states, you can detect them earlier, even before the radiological specific sign which comes up. So these biomarkers are becoming more and more important nowadays. Now biomarker may not be of the disease associated biomarker. It may be also your physiological condition biomarker, like your degree of stress can be detected by your endorphin level estimation also. So there are a lot of these biomarker sets are coming up. Your intermediary metabolism can be assessed by a particular biomarker which can tell us whether there is an alteration of your glucose metabolism, alteration of your lipid metabolism, and any other metabolic abnormalities. So that means this biomarker research is becoming more and more strong. But then, as a physician or clinician, even in those who are in dentistry practice, you have to realize, unless you know the understanding of the validity of the biomarker, you cannot order those tests. You will be doing it either unnecessarily, or you will be doing it when it is not, when it is indicated you will not be doing it. That's why I am saying that the understanding of the physiology and pathology is extremely important, both for diagnosis as well as therapy. And biomarker identification is all the more important because nowadays we are practicing the targeted therapeutics. So molecular targeted therapeutics, which we are calling as molecular medicine, success depends upon the biomarker. Quickly I'll give you an example. I think those of you know that in oncology practice we use a lot of immune checkpoint inhibitors and very specific antibodies. Now these are very costly. Each cycle can cost the patient, for only one dose can cost the patient almost the 2 lakhs to 5 lakhs. Now that application depends upon very specific biomarker positivity. Otherwise it will be total waste and nothing will happen to the patient and no cancer regression will happen, and then you will be using this biomarker very, very falsely. So that's why it is very important that biomarker concept is very important for you to understand. Sorry. Oh. Yeah. So, I think now what I have told you, I'll just try to summarize it very, very simplified way. So when a patient comes, obviously you do a clinical diagnosis, then try to look at the organ. So this particular case may have presented with a signs and symptoms which indicates there is a defect in the kidney, that is excretory organ. And then see, nowadays in kidney particularly, if we suspect the huge protein is coming out in the urine, so we know that that is because of, I think, the disease of the glomerulus, which is the filtration unit. And if there is a leaky glomerular disease where a protein is getting leaked, then we know that the glomerulus is the site of the disease. So then usually nowadays current practice wise biopsy is done, and in the biopsy we see them morphologically what is the change, and then even one can do, this is a light microscopic image, and then in the below you can see the electron microscopic image. So you can go down beyond the light microscopy to see exactly what is happening in the cells which are maintaining glomerular filtration barrier. Then after that you reach a diagnosis and then the therapy is given. So this is actually combination of the clinical diagnosis, pathological diagnosis followed by therapy. But then there are certain subsets of disease which may not be clear even by doing all these techniques. So these are due to genetic alterations, and these may be quite a bit of familial disease which can affect the kidney. Even if we do these two tests, we may miss those familial incidences. So for that, you have to do the molecular analysis or molecular diagnostics. Now, to make it very simple, this is the central dogma of the biotechnology or molecular biology, you have every cell, even the structure and whatever component is there, it consists of a protein and protein complexes. These proteins are basically translated by RNA, ribonucleic acid, and this RNA translation depends upon the activation of the gene, specific gene, through the transcription, and which activates these RNA, and then the RNA translates the protein. That means each of the protein depends upon the genetic sequences, and if there is any defect in that sequence, or there is a defect in the RNA translation or transcription, you can get alteration in that protein. If the protein is altered, then the cell cannot function normally, and you can get the abnormality in the cellular function or structure, which can give rise to the disease. So that is the central understanding of the thing. As I told you, we are looking for biomarker. So what are the areas we look for the biomarker? We can try to analyze the protein, then which we call proteomics, and to find out the defects. If we find out the defects, we can have a proteomics biomarker. If there is a defect in RNA transcription, then we can analyze that and we can identify defect in transcriptome. We use the word transcriptomics. And then if there is a defect in the DNA itself, gene itself, then we can pick it up. Then that biomarker we analyze by genomics, gene analysis of the genes. So that means this central theme can be explored by genomics, transcriptomics, proteomics. But these are not theoretical. In many of these situations now, in cancer particularly, hereditary disease, like I'm not going to the disease specific details because there are, I can understand, specific traveling here. So that means the way we are going, we are picking up the molecular diagnostics at this different level, which is subcellular. It is not the structure of the cell. It's all going deeper and deeper. Okay? So you have to have that kind of understanding. Now, coming down to the disease, that means there is something abnormal, there is some pathology happening. So obviously, we can look for alteration of the structure, we can look for the alteration of the function, and then structure and functional correlation to understanding of molecular interaction. I think I have explained very briefly or lucidly in my last slide. Now, as I am talking to that, when we develop the devices or the techniques which takes these devices needs the knowledge of your physics, chemistry. We may not have, but then they definitely will have, and biology, and then there are a lot of computational mathematics coming up. See, when we do a DNA sequencing, we get a sequence, but sequence matching is done by different kind of software. Now, the NGS, which is the another form of sequencing, which is becoming very, very popular nowadays, it has got huge bioinformatics backup is needed for that. Because these data, the human genome has got almost several billions of these genomic sequences, which is in the computer system. But then, which you have got abnormality, it has to be compared. So these are done by the bioinformatics and mathematical modeling, computational modeling for the system biology. So that means it may not be done by you, even if you are a physician, but you have to take off a help of bioinformatics person or computational biology person who will be helping you to understand this abnormality of the particular gene sequences. Now, as I have explained to you, so nowadays we are going towards the molecular medicine, and finally we have to go because things are moving very fast. So if we go to the precision medicine or molecular medicine, so these areas, it is helping your early detection of the metastasis, I have explained to you, by different kind of functional imaging system. And you can have a very targeted therapy. Say for example, in nanotechnology based drug targeted therapy, like we have developed a couple of them. One of them, two of them are now technology transfer to the companies. What we try to do is that, see, for a very particular cancer targeting, sometimes we use the antibody tagged with a nanoparticle. This antibody is against the specific receptor of the cancer cells. So if you inject them on the vein, it can home into the cancer area. And then it carries the nanoparticle. In the nanoparticle, we load the anti-cancer drug. So that means when we give the systemic anti-cancer chemotherapy, the blood, the level is dependent, the actual effect of the tumor depends upon the blood level. So that's why when these chemotherapeutic toxic molecules or agents are high in the blood, you have a lot of systemic effect. Like your hemoglobin goes down, your blood cells are getting destroyed, hair falls, may have diarrhea because the intestinal mucosa is affected. But if you have this kind of targeted kind of the cancer therapy, then your drug will be accumulating through the nanoparticle targeting system inside the cancer. So you have no systemic side effects. And in fact, very less amount of drug you can use through this nanotechnology-based drug delivery. So this is the technology which is important. And then even if you don't, they do the antibody tagging of these nanoparticles. If you make this nanoparticle around less than 100 nanometer, usually 20 to 50 nanometer will be better. Then this is a system called EPR. There are the capillaries inside any cancer or malignancy is very abnormal. So there is a lot of gaps between the endothelium of the capillaries. So whenever we inject this nanoparticle, they pass through the inside the vessel and accumulate into the interstitium of the tumor. And that's why this kind of the accumulation can happen. And so you get the drug accumulated, the differentiate, the sequestrated in the cancer area much higher concentration than it is in the systemic circulation. So these are now the docetaxel, which is the one of these nanotechnology-based therapy, which is now available in Indian markets, in the Abraxane, which is paclitaxel, loaded in albumin nanoparticle, which is used for breast cancer and some other cancer. So these are all now in practice. So now, if I try to make things summarize, so there is a genetic defect in the gene. It may occur due to mutation, due to many things. I mean, defect in the, I don't know the detail. That will cause the alteration, either structure or function of a tissue or cell. That will cause the alteration of the system biology, decreasing all the lung, develop the cough, the pulmonary fibrosis, the other kind of lung disease. If we involve kidney, we can have the proteinuria, hematuria, and there are a lot of abnormality involving the kidney. So, like depending on that, so that depends on which system is affected. And then when you try to investigate, I have explained to you, you can go to these genomics, proteomics, transcriptomics, lipidomics, metabolomics. So these are basically the specific molecular detection, which is specifically related to that disease process. And then come the organ function alteration, obviously we will be picking up. And then cellular dysfunction and metabolism also we can access by this. Now, normally, there is a huge role of cell-to-cell interaction. Now you know how this cellular control system works. We have got these endocrine, like thyroid, T3, T4, which have got wide spectrum effect in all these different cells and organs. You have got growth hormones. So this is the endocrine control from all the different organs. Similarly, cell-to-cell interaction can happen by active factors. Like some of the factors secreted by the cells can have an effect on the cells which are a little away from that, but not like endocrine which have got an effect on the whole, the total body of the cells. Similarly, we have got the autocrine function where certain factors are produced by the cells which actually act on the subcellular organelle of the cells itself. But then nowadays we know that this kind of cellular interaction and control is not by these three mechanisms. This is also done extensively by extracellular vesicles. Extracellular vesicles are called also certain subset called exosomes. Now these exosomes, these are small vesicles which are actually secreted by the cell itself, and they carry some amount of these microRNA and other molecules which goes to the other cells and communicate with the other cells. Now, exosomes are supposed to have quite a bit of role in both in physiology and also pathology, like cancer cells is suspected, and then there are the different kind of other metabolic situations exosome can alter. So nowadays, exosome has an advantage. The RNA content inside the vesicles can stay for long. So on immunity exosomes now we are working and we are trying to find out whether we can have a relation with the different kind of renal disease which we are getting. Similarly, the exosomes, stem cell therapy is a big challenge. You know the stem cell therapy because still we are not sure because whether these stem cells, if we are injecting them inside the body, whether actually they integrate with the damaged organ and acquire the function of the organ, still it is really controversial. So we are nowadays shifting towards exosome based therapy. So what we are trying to do, we are getting these mesenchymal stem cells and induce them to produce a lot of exosomes. So these are no nucleic acid in them. They have got small amount of protein, mostly baggage of RNA, microRNA, which is the controlling RNA, and then covered by the small cell membrane part. So they don't have any nucleic acid. So if you inject them, so there is no danger that it will cause an alteration or cancerous transformation. There is nothing like that. So exosome therapy is also coming in a big way. This is particularly important in acute lung injury, then acute tubular injury in the kidney. So exosome therapy and both diagnostic and therapeutics is coming. Now this will be pathology, but I think the example of pathology itself. There is a theory that if we get some few cells or small amount of tissue, so then from that, not only we can do morphology, but we can do the immunohistochemistry or immunofluorescence to study the different kind of functional aspects like what enzyme present or not, whether receptor expression is up or down. So all those things we can do. And then also we can study the gene expression. The gene expression can be done by different things you have technique, where these faulty genes can be picked up by fluorescent-based the marker system. I'm not going to detail about that. Now, we have done a lot of work and published a lot of work in this area. So again coming back, summarizing. So when we talk about these biomarkers, the biomarkers initially I told you important for diagnosis. It's not like that. The biomarker can be important for prognostication. Like there are certain kind of biomarkers which indicates it's a good prognosis, and other biomarkers which can indicate the bad prognosis. So for example, even morphologically a cancer looking same. I can give you an example of a breast cancer, particularly some of these even ER positive breast cancer behave much well. I mean they have a very long cancer-free survival. Whereas in same kind of morphology, some of them has got a very poor survival. Finally they develop the resistance to a lot of therapies down the line and the patients, we lose the patient. So nowadays we are realizing that there are alteration of this response depends upon certain intermediary metabolism of the cancer cells. And that can be picked up by other sets of biomarkers. And that we call the prognostic biomarker. The prognostic biomarker is becoming more and more important. So for example, in even the chronic kidney disease, in chronic heart disease, there are certain factors related to fibrogenesis and resolution which you can pick up. So that's why these prognostic biomarkers are becoming very important nowadays. And then comes the therapeutic target. Depending upon, as I told you, nowadays if you go for biologic therapy, then therapeutic target identification and confirmation is extremely important. Otherwise we will be losing a lot of these the money without any effect. Now these I have already explained. Now I'll give you a small concept of epigenetics. You don't go into the detail. See, normally I have explained to you the gene expression is important for both the physiological conditions as well as in pathological development of disease. But then gene expression can be regulated by the epigenetic factor. And epigenetic factor are there, all individuals. So this epigenetic mechanism, what it does, it controls the gene expression. It can put off the gene expression or it can enhance the gene expression. Now, these are done by 3 different things. You may not remember that. So what it can do, it can attach methylation of the DNA. So the DNA, it can methylate, so methyl component can be attached to the DNA, and if it is attached, then the DNA cannot express. So more and more DNA methylation, less gene expression. Similarly, there may be a non-coding RNA. These RNAs don't do the transcriptomic, that is expression of the protein, but they block the expression of protein by blocking the transcriptome pathway. And third is that histone. Now, if you remember the structure of a gene, there is a protein also which helps in convolution of this gene. If you see the chromosomes are highly convoluted, so if these coils are very much tight, then gene cannot express. So histone can modify the DNA coiling. So these are the 3 mechanisms which can have the control of the expression of the gene. So this is the epigenetic factor. Epigenetic factor depends upon your habit, your diet and your environment. That means you can train yourself. That's why we always advise you should have a good healthy living. You avoid the fast food, you avoid smoking. In smoking, it is shown that there are HRA genes which are, if you smoke more, so this is DNA sequencing is suppressed. So DNA expression is suppressed. So when you stop smoking after long smoking, it takes months and years to revert back to normal situation. So that means nowadays the epigenetic understanding of the disease is becoming more and more important, because we can modify our food, we can modify our lifestyle to prevent the disease. And before disease developed, so epigenetic marker understanding with each individual is becoming more and more important. So though it is not routine nowadays, but as the epigenetic markers are very well defined, so I am pretty sure in down the line near future, the epigenetic investigations is going to add to our routine investigation in medicine. So I am not going to the detail of this mechanism. Now I will give you another concept. For detecting any biomarker, what you do? See, we do usually level technology. Level technology means you use an antibody and do an antigen-antibody reaction and detect them. So this is true for ELISA, that is enzyme-linked immunoabsorbent assay, EIA, enzyme immunoassay, immunofluorescence, immunohistochemistry. These are all level technology. But nowadays, there is a rapid expansion of the unlevel technology. You don't do anything. You get the body fluid, get the blood, and put into the spectroscopy. You will get the molecular signatures. So advantages are, you don't need to spend time and energy buying these costly immunological reagents and do the test. So the unlevel technology is becoming more and more important nowadays. These are all level technology. This is one of the other concepts which is coming with changing the laboratory, the investigation portfolio. This is by lab on a chip. So lab on a chip, these are basically in a, say, whole structure is about, say, 20 micron or 30 micron. It's a very small chip. And under which these channels are is less than 1 micron. This is in nanoscale. So if you put your blood over here, maximum we take around 20 microliter to 30 microliter blood. It goes to, so there is separation of these cells. Electrophoresis can be done with the system. There are also specific antibody. So your immunoassays can be done in the system. Then you can have a PCR also inbuilt. You can have a different kind of DNA analysis, sequencing analysis in the system, and finally your reflex will come out. And this kind of lab on a chip is coming with microfluidic devices, which are making your normal biochemical laboratory redundant. And it is predicted that in down the line, definitely 10 years, most of these point-of-care devices or lab-on-chip devices is to replace your huge autoanalyzers, because you don't need them, because these are highly cost-effective, because your reagent requirement is less, and your air conditioning and all those high-power things. So these will be very, very energy efficient. You don't need the stabilizer, huge voltage protection for big autoanalyzer running. So these kind of developments are coming up very fast, and near future it will be important for us. So see, I'll give you one of the example, nanotechnology based the system we have developed. See, in prostate cancer detection, it is difficult. It is not possible by urinary biomarker. So we realized that we develop prostate specific antigen, and there is another molecule MSMB. Now, prostate specific antigen goes up when there is a cancer, and MSMB goes down when there is a cancer. So if we take the single molecule, the chance of false positive and false negative is very high. So what we did, we developed a system where the nanoparticles are tagged with these, the quantum dot are fluorescence dots at the level of size is around 3 to 5, 3 to 6 nanometer, and we tag them with the specific antibody both for the PSA and MSMB, and we have shown that you can detect it. Basically, in cancer group, the PSA will go up and MSMB will go down. So if we do a dual marker simultaneous study, then it is possible to detect them very easily and follow up these prostate cancer patients for screening and as well as follow up treatment. Now, as I told you, the spectroscopy is coming in a big way. This is an unlabeled technology for molecular detection, and the Raman spectroscopy is one, which is obviously Indian contribution of the Sir Raman is there, who got the Nobel Prize. What happens is that if there is a change of a particular molecule, you can have the difference in the light scattering. At the moment the light scattering the difference is there, you know that this molecule is normal, not normal. It is abnormal. So this kind of molecular alteration can be detected in the tissue fluid. So these prototypes are now available, where little bit of fluid collected from any body fluid with this Raman spectroscopic electrode, you can connect to the Raman spectroscope and you can detect the difference of the molecular signature of your fluid. So these kind of technologies are coming up. This is the Raman spectroscopic microscope. Now, these, if you see, this is the light microscopic. In the light microscope, you can see in the rightmost, this is a of the breast cancer area, and you can see the beyond that gap on the left side there are these cancer cells. And if you see in the spectroscopic image, you can pick them up with that red signal. The red signals are indicating the presence of cancer cells. Now the validations are going on, so it is possible then that the cancer margin detection in the OT, operation theatre, during removal of the cancer is becoming very, very important. What do we do nowadays? We do frozen section. You take a tissue, go it for frozen section, pathologist see it, and then tells the surgeon, no, still there is tumor, so he cuts little more, like that. Now if you can develop this sort of Raman spectroscopic imaging, along with the needle-based spectroscopic molecular operation detection, then it is possible to detect the UV operation as a part of the procedure. So the quantum-based technologies for imaging is coming up. I'm not going to detail for that. So this is one of the projects I think now for translation we are developing. After my retirement, I think Dr. Tucker has picked up the project names. So what sentinel detection is a major challenge. That is, the early cancer cells are deposited in the lymph node, and for detecting that, we are either use a methylene blue. So we inject the dye in the subcutaneous lymphatics in the near the tumor, and if there is metastasis, these lymph nodes become blue because it accumulates in that. But the false positivity is almost 40 to 50%. Similarly, we use the radioactive sulfur colloid. Same principle, the radioactive sulfur colloid accumulate in the lymph node where the metastasis is there, but the false positivity rate is high. What we have done, we have used the anti-epithelial antibody and then tagged it with a technetium-99 level nanoparticle. And then if you inject it in the subcutaneous tissue in the lymphatics near the tumor, then the lymph node where there is the epithelial cell metastasis, it specifically picks up the radioactive tagged nanoparticle, and if you do the radionuclide scan, you can detect these lymph nodes very well. So this is a par-operative procedure. You don't need to, it will be bypassing that, sending frozen section, getting confirmation of pathologists. So these kind of technology can be developed which can change the normal practice. Now another huge technology is coming up which is called single cell technology. Single cell technology as you know, that in a cancer, there are a lot of cancer cells. Some of the cancer cells has a capability to become stem cell. So these are very difficult to eradicate. But the stem cell population in a cancer biopsy may be less than 1%. It's very difficult to detect them. So that's why detection of those cells are very important to prognosticate that case and also to develop the strategy of therapy. If there is more of cancer stem cells, then instead of 3 cycles, you can continue to 6 cycles. Even you can alter the composition of your adjuvant therapy. So for that, you need a small bit of tissue, and each individual cancer cells has to be analyzed. Otherwise, you cannot detect them. You can run a flow cytometry, less than 1% cell is not possible to detect. So that's why these kind of technologies are becoming very, very important. This is also becoming very important for AMR microbiology. Single, very small populations of these bacteria, they can be picked up, and which can predict that further development of a future development of antimicrobial resistance to particular antibiotic. The high throughput tandem analysis by the mass spectroscopy, these clinical mass spectroscopies are available now. In India, unfortunately, I think we have not established those centers, but I think we are proposing in JNU to establish the center in a experimental basis, just to see the efficacy of this kind of system. In US and other developed countries, the initial screening of the done with very high throughput. Say the 20,000, 30,000 samples they run through mass spectroscopy, tandem mass spectroscopy to detect the abnormality, and then they screen and do the other specific investigation. In India, we have not started this kind of practice. So these are going to come. So these are basically unlevel technology, high throughput technology development. And so now I think towards the end part of my talk, the old way is that we used to get the tissue sample, cellular sample, and to do the pathology. Similarly, in the microbial field also we used to get these samples, do the culture, isolate that and characterize that and give a diagnosis. But nowadays, what is happening is getting a sample and then you can isolate the cells, do a proteomic analysis, do a mass spectroscopy for proteomic, the fingerprinting, and we can do the genomics for different kind of the genetic sequence of diagnosis, and you can even do the microarray technology development. So finally, I think take-home message is that there is a rapid advancement in my understanding of molecular interaction related to pathobiology of the disease. I have given you a lot of examples, very simplified term. And then also it is possible to detect the diagnostic and prognostic molecule as biomarker as well as the therapeutic target for particular disease. I have given you some examples of that. It is possible now, and more time we get, more and more these new technologies will to come up to do that. So that means your medical practice, what you are currently doing, is going to change also in your future. In 10 years time, definitely, I can assure you. 5 years, well. So but then you people are all young people, when you will be practicing your life, what I'm talking actually, most of them will be in practice. So the conventional practice which you are doing is going to change. Digital pathology, say for example, those of the pathology, is becoming coming in a big way. But digital pathology optimization in India is still not done. In AIIMS, we are trying, our faculty or myself, we would like to see the microscope, try under the microscope, look into it, look at that. But nowadays what is happening, you can get a whole slide imager, get the image in your big screen, and then you can look at it, and there also there is AI which point out what the computer field is abnormal areas. And then you can validate it. So their chance of missing will be much lower. But as they are not very comfortable with that kind of technology, yet we are not practicing that kind of technology. But anyway, it is going to come. Then we are progressing to an era beyond the current mode of practice of every area. Digital cyto is one, but I think in microbiology, radiology, I have given you a lot of examples. And the field of diagnostic pathology will be based on biomarker for detection by the advanced technology which may appear science fiction now. Many of the things I told you, like spectroscopic imaging combined with the proteomics. So nowadays we are talking about multiomics. Even the imaging data, we are calling them radiomics. So we are trying to correlate clinical features with the omics data, and then genomics, proteomics data along with radiomics. So this is called multiomics. So multiomics integration will be possible through computational and informatics approach. So obviously, then whole role of the physician is going to change. And then I congratulate all the young pathologists particularly, because the era of omics is coming in near future. This is not only for the diagnostician, this is for also the therapeutic areas. The omics is coming in a big way. And that's why we are proposing to relook into the capability or capacity building. And in fact, we need to change our whole the understanding of the medicine through changing the teaching and training process. Because though they are yet to come, but they are definitely going to come. So giving you a small exposure that these are these areas you should follow up. See, I have not given any specific the technology area lecture. Like even in the dental practice, there is a rapid advancement is coming in the material area and material tissue interaction area. And also there is coming the 3D bioprinting. So 3D bioprinting is coming in a big way. So basically your denture is now individually personalized, can be made, and then based on the image, CT image of your oral cavity. And so these technologies are coming up. Because of cost effectiveness, I think it has not come in a big way in India, but near future they are going to come. And in also dental practice, there are the cavity specific targeting technology is coming up, the photo activation technology is coming up. So there are many of these new technology coming up for medical intervention. So thank you very much for your attention.
Sir, I must congratulate you for giving such a nice and informative talk to us people, and it was quite interesting to know that now we are going towards a genetic scenario where diagnosis will be based on these things, genes and all those things. So I was working in Gulf Medical University, where they are already doing this genomic sequencing, and for many of the teachers, the faculty, they are doing research work on this sequencing part of the various diseases. So now it is going to be all genes now sequencing. So in India also through ICMR, the facilities may be provided to the various medical colleges and the interested researchers to carry out their research work based on the genomic sequencing and all such things which you have just told us. So I think and non-invasive technology is going to come where we don't have to draw blood and take out tissue portion for this thing. So is ICMR doing something in this regard, that they are providing facilities to the interested researchers for this field, sir, which you have mentioned about genetic sequencing, all such things?
So basically, is a major challenge in particular situation. So the regional center development,
Yes.
The facility development. I can give you the example of the virus. Now, any major viral problem, no virus is suspect, you send it to NIV. Virology. Technology where the new virus can be detected quite easily. So problem, I will tell you the problem with my experience. See, I picked up, I think, almost 6 years back when these AIIMS came in a big way. So I initiated with our dermatology faculty one of the rare genetic disease, that is EB, that is erythematous bullosus. These are newborn children who develop bullous disease. This is definitely a genetic factor, and this is a familial also. So when we started doing these NGS of these Indian newborn, so we had around 70 patients. We did the conventional the identification, where we did the pathology as we do the collagen disruption markers by fluorescence, by electron microscopy, apart from light microscopy and other immunological techniques. And then normally these techniques have got a maximum success rate of arriving diagnosis around 55% of cases. But then if we do a proper genomic analysis, then the diagnostic rate becomes 80% plus. When we started doing that, we were using the database, genomic database of US. So the student, PhD student, he has completed the study in 3 years. So we were collaborating with IGIB, and because they have got very good capacity of analysis of the genomic data. Success rate came down to 45%. So obviously I was worried when the published literature says genomic analysis gives you 80% plus the success rate, then why we are getting this? We realized in Indian scenario, the normal genetic analysis data we don't have. In fact, AIIMS has started the normal human genome data for the Indian population because it is very, very important for that. So that's why many of these things now routinely we are sending sample to Bangalore hub. There are a couple of companies in Bangalore who does NGS for you and give you the report. Many of the report we are realizing not particularly matching with the particular clinical suspicion or diagnostic because they are also using the US gene bank. So obviously down the line, as we will be doing more and more of these genetic analysis, I think it will be possible to develop our own the normal genomic data and bias system. Thereby the accuracy of these diagnoses will be higher. So nowadays it's costly, but you can send your sample for the sequencing to private the companies. But I think the ICMR and other institutions are also trying to create that. Because currently government is also moving towards, even in the government setup, moving into the commercial viable option of the high-end technology. So these will be, I think, open up very soon to the user across the country.
So one more thing, I just we know that whenever there is a new research, it is on a molecular basis in Europe or American countries, and then whatever they are doing, we are just copying it. So the one of the reasons is that electron microscope, etc., these sophisticated things, they are not available to the medical colleges here or to the research organizations here in India. So are you aware that why those people are finding out everything and
no,
we are just following things?
Tragedy is that, so I told you I was associated with the Electron Microscopy Society of India. In India, there are more than 200 electron microscopes across which can be used for biological the sample. Most of these electron microscopes are there with the engineering institutions and as well as basic science institute. Unfortunately, because of our lack of collaborative understanding, they cannot be used up. So the DSC has set up some of these national facility for electron microscopy. But I agree with you that even if we have got lots of these electron microscopes in India, for diagnostic purpose use is very, very low because that facility is not there. For kidney biopsy now, electron microscopy is mandatory for all biopsies, almost all biopsies, except maybe around 20%, 15 to 20%. So around 80% of these kidney biopsy for definitive diagnostic electron microscopy is must. But we don't do it because basically AIIMS is doing because we have got electron microscope facility, and recently we have got an absolute electron microscope for pathology department. So they are particularly for this kind of data generation. But I agree with that our actual gaps are there. Even if you know what is to be done, but from where it is to be done is still a big challenge. And
funding, because in Gulf countries there are many organizations who are giving funds for research. But in India, unfortunately, no one is giving funds to a researcher, a genuine researcher, sir. That is one of the factors why research is better in because of the and the medical colleges, they are opting for MSc PhDs because PhD people, they bring funds for research. So now in whole world there is a demand for PhD people, and we are MBBS MD, we have failed outside. They are not hiring the medical doctors from India, but they are opting for those people who have done PhDs, sir. That is one more thing.
Yeah, the other thing which you can do is that Government of India now started the capacity building for research. So in that, so I am in both the committees for DSC Inspire Fellowship and also DHR the Fellowship for PhDs. So these I think your faculty can apply for that. The advantage is that we are now looking for need-based research. We are not giving money for these the research which is already published and you are modify a little bit and write a proposal. We are not giving on that kind of project. But if you find out, if you define that this is a need which is to be explored particularly in Indian context, then we are giving a lot of money. In fact, last month we have 480 DSC inspired fellowship we have given to different colleges. But unfortunately there medical colleges don't apply. From AIIMS there are only 3 applications. And then Jamia Millia and Jamia Hamdard, so these 2 institutes, they have given almost 80 applications. So we realize that these awareness has to increase, that there are a lot of new kind of funding is government has started. Now these fundings can be easily brought in even for the institution. We are not now discriminating between private institution and the government institution nowadays, because the DSC is very clear about it. So capacity building has to be done in private institution also. So there is a scope that from this kind of institution also to come up, because you have to just see that the portfolio of funding has changed recently in the last 1 and 2 years in most of these situations. DSC, DBT, ICMR, DHR. These 4 will be, DSC will not be, DSC SARD maybe give you money, but DSC Inspired Fellowship can be given in biomedical area. But DHR and ICMR has developed a lot of these fellowship given to the students. So for that, they get the total fellowship for 3 years on their own fellowship, and they get between around additional 10 lakhs per year, so 30 lakhs in 3 years for community and all. That's a quite a bit of good seed money to investigate quite a bit of things. And nowadays also, even if you don't have that instrument, but you can outsource that research. So that component you can do it from another lab. So that money is also given in the research. But then obviously, for a PhD thesis, we want that the candidate should do something, learn some techniques also. So, but then these are all changing to the past. For exploratory research, government is not giving money much. But then if you have some idea which has got translational value, there is a lot of funding we are giving for translational research, for developing new diagnostic, new health intervention, substitution of the imported material. So that kind of need-based research is getting a lot of money, not the earlier research method. So in fact, in near future, maybe down the line in 1 and 2 years, funding for all exploratory research will be stopped. Because we don't want to do the repetitive research and the same wheel, reinventing the same wheel. So the current science policy will come up very soon. So 75 years after independence, we have pursued only so-called exploratory research, where mostly we have reinvented the same wheel. It has not helped us. So now that's why need-based research, if you do, even if it's a small need, but if something can be come up with that which is useful, so useful research outcome is a major issue now. So that's why I think it is possible to bring in some amount of research money to these institutions. It only we judge about the quality of the proposal. And nowadays the direct presentation is stopped. So that's an advantage, disadvantage. Advantage is that if you can write a very good proposal, it is almost true. Because earlier we used to cross the presenter for his knowledge, for his this thing. Nowadays we are not doing that. So we are seeing already he has done which area he is working, he or she is working, and if 1 or 2 you have publication or some evidence that you are already in that field, so it is done.
Thank you very much, sir. Thank you.
Good afternoon, sir. Thank you very much for your very informative talk. I just want to know about LOC, lab on chip, the spectrum of tests which can be done, the time required and the cost.
Yeah, so what happens is that now the imported lab on chip if you forget, but then there are the quite a few Indian companies which are developing these lab on chip. So there are the several technologies. One has got very simple, the flow-based technology. I think these companies, 2 of these companies are integrated with us. So one will be available for your routine biochemistry, where the glucose, the NFT, and then serum creatinine. So they are not developing for the whole array of tests, But the major test, screening test can be done. The cost would be very, very low because I think we are calculating out of a part test of say the 6 to 10 parameters. It will come out to be hardly 30 rupees to 50 rupees. So that kind of the low cost technology. So they are under clinical trial. I think the two of them are in practice clinical trial. We have picked up one where they will do the PSH estimation. And this is particularly we want to enforce for rural areas for pregnancy and newborn. Because thyroid abnormality in the pregnant women and the newborn child is undetected, goes undetected, always they develop certain symptoms in pregnancy. So that's why these things are coming up very quickly. And in fact, they will be introduced to the Indian market, some of them in the next year itself. So you will be able to know what are the.
So workload of the technician will be.
Yeah, there is lot of advantage.
No.
Most of these technologies are coming up with the self-analyzed readings. Yeah, so there will be always, see, I tell you, ये जो अभी कोविड का वो IgM टेस्ट है जो पेपर स्ट्रिप बेस्ड टेस्ट, these are gold nano based microfluidics but very true form. These are little advanced form. They will have a similar kind of thing. So the color development depending upon your MRI will be detected by the photosensors, which will get and read and view the result. So these technologies are now easy to do, easy to start. What we are trying to do, we are trying to see that gold standard comparison, how much is accuracy. So even if it is coming around 85% plus accuracy, and then we are giving green signal to the market because in any case, 85% of these cases it will solve the issue. And another 10-15% if there is some of these borderline things are there, it can be tested by the conventional. So they are running very fast. In fact, so you don't need to have for many of these days the so much of auto analyzer and capsule building. Yeah.
Then apart from biochemistry, what other tests can be done? Immunology.
Yeah, so the reading assay, there are easier technologies which are coming up. So normally hormone detection technologies are costly. So there I think the supplementation with the microfluidic technologies are coming up. In fact, we are incubating one company who has developed the TSH estimation. And then also the PCR. Now the one startup in the IIC Bangalore, they have developed a PCR which is this much machine, and these are battery operated and will be very, very cheap to handle. So the indigenous things are coming up now, and so they will be replacing many of these now the imported technology or instruments which we are using. So that's why down the line, we are hoping that in 2 years' time, many of these will be marketed. For you people to acquire those, they will be much easier. The government system है ना वो उनका हमारा वो प्रोसेस होता है क्या कहते हैं वो टेंडरिंग क्या है L1 हाँ L1 तो ना L1 में चाइनीज बहुत प्रॉब्लम कर रहा है वो सब में L1 कर देते हैं इंडिजिनस टेक्नोलॉजी इंडिजिनस सेलिंग के लिए ना आपको वो होता है एक उसको अप्रूव कराना पड़ता है वो कराना पड़ता है so government system में we have any little trouble to get these new systems but for you people there is no issue because once the DCGI certification is there this is a valid test and then you can start it there is no issue in that and the report will have the reference of quality system and everything which is approved by DCGI so these are coming up in fact so and even the microbiology sector also there are quite a few changes happening because after COVID there are a lot of indigenous the breach PCR technologies being developed. But these are will be also commercialized very soon. So nowadays we are not encouraging the COVID, we are encouraging the same technology to be used for other infections. So उसमें सबसे बड़ा challenge है हमारा microbacterium tuberculosis. Because we suspect that the drug resistant tuberculosis का incidence जो अभी हमारे पास डाटा आ रहा है, the data we are getting they are not correct. Because actual incidence of drug resistant tuberculosis in the community is not being that. And that's a really big danger. So in fact, so that's why we are now trying to introduce the new generation of the test, which will be much easier to do.
And also it is feasible for you to arrive at diagnosis in the lab based quickly and relatively accurate. So you have to understand that what I showed you, there is a rapid development in the engineering side, in the physics and technology application. What we are trying to do is that we are trying to bring in more medical experts into that from the conceptual stage itself. Most of the things again, I can tell you what is happening, problem is still happening in India. Here our habit of interdisciplinary research and collaboration is very low. That's why even in the IITs and IISc, ISAs, they are doing extremely good research. Application side, they have never consulted a good doctor. But you won't be surprised that I am not in the IIT, it's a big IIT. I think we given them 5 crore fund to develop the dialyzer, Indian made dialyzer, dialysis. They have all that expertise to develop that polymer with high flux and moderate flux. When we told that you need a clinical collaborator, that guy was a dentist. So it got fast because of Dr. Kalam. They forgot to see there. And then after 2 years, when we go into the site, we realized that it didn't move because basically they read the article and did it. Application side, क्या करना चाहिए उसमें अगर blood coagulation बढ़ा रहा है कि नहीं, so they have not done anything. Then which is the doctor was there, the dentist. So those kind of issues in India, hopefully is no longer will be there. But nowadays there is a change that interdisciplinary research, even in your setup, where there is an engineering institution, medical institution, even if it's a small topic, but if it is possible to collaborate with some the clinical department to look into certain things, even small things, but that kind of interdisciplinary research habit will be very important to enter into these fields. So these are, even if we don't go to so much high-fi thing, but even some of the color change detector, some sensor applications, these things can be done. pH applications. So usually pH also do a pH paper, but more accurate pH estimation with sensor can be done. Where the possible chance of UTI or other factors which are totally changing the pH scenario of a particular patient can be used. So there are a lot of small scope and of developing things.
Application also.
Yeah.
Thank you, sir.
Professor Dinda, Professor Dean, Raman and faculty and all the faculty of NIMS and students. It has been, I think, an outstanding presentation by Dr. Dinda. And two things are quite obvious, and I just want to bring them to notice again. Number one is that the medical education that we are getting, or the textbooks that we are reading in our medical professionals, we have to understand that they are going to change very rapidly, so we have to be ready for the change. So, things that are like totally contraindicated in the past, we find now have become of choice. One example that I can give from cardiology is that it was said that if you want to kill a heart failure patient, you give a beta blocker. And now if you see, it has become a drug of choice and actually reduces mortality. So, it has been a total upside down in that area. And I think what all of you have to understand is that whatever you are reading today is contextual today itself and can change in the near future. So you have to be prepared for the change and accept that change and be ready to dive into that change. Because if you don't accept that change, then you will be lost. So I think that is the number one point. The second point that we made was, I think, also very important, that the time has gone where, classically what we used to do MBBS and then specialize in something, do MD, and then super specialize, go to DM or MCA, something like that. Now I think there is a other way around. You have to go back and you have to go back and do maths. You have to be ready for engineering. You you have to be, having a look at the big picture now, rather than the small picture. So I think the time has come where one should have a broader vision to understand what is happening in today's world to be successful in it. And the third point, I think he brought out to some extent, was that, we used to think where is the consciousness of, see what is the difference between a living thing and a non-living thing. So if you think about it, one of the differences is that the living thing has a choice. So we think that any living thing has a choice to do something, compared to a computer or a machine which has no choice. So if you put something in computer, it will give out an answer, but it will give no choices, it will just give one answer. But a human being or any living organism always has that choice. So the thing has been where that choice in a living being resides. And people used to, look at the thing, and looking at bigger organs, they thought, okay, the choice, some people said it resides in the heart, other people said no, it resides in the brain, and that controversy goes on. But at a molecular or a cellular level, people used to wonder where that choice resides. What is the master organ or some organ of a cell? And people thought that nucleus is that master organ because that seems to be the thing. The problem with this hypothesis was that there is a cell we know is living cell, it lives for 120 days, which does not have a nucleus. And it can do other things, and that is red blood cell. So red blood cell is a cell without nucleus. So if the consciousness resides in the nucleus, then how come it is there? But anyway, people thought, even read further into nucleus, and they thought that maybe DNA is the master controller of the whole cell. And then, then again some problems came when they sequenced the whole DNA, Venter did that project, and I think many people will be aware. They realized that only 15% of the DNA is functional. The rest of the DNA, or even less, was functional. The rest of it was non-functional. So if something resides there, then why is it that most of it does not function? So that was a very alluring or very this sort of question. And then came epigenetics, which said that most of the DNA can work only if it gets activated. Most of the DNA is in a dormant state, and part of it can work only when it gets activated. So what is that master activator that activates the DNA to do the work? And so that was the big question, and then people went down and they realized that perhaps the cell membrane is the master organ, and cell membrane in contact with the environment can influence the DNA and make DNA do whatever work it can. So I think we have moved to that stage, and what Sir was also mentioning, that the environment is very, very important because that affects upon the cell membrane, and then cell membrane makes DNA do whatever work it wants DNA to do. So DNA is important, but as you can see, only 80% of it can be affected, 20% still left. So cell membrane perhaps, and then lifestyle. Lifestyle creates that environment, and that environment acts on the cell membrane, and that acts on the. So I think this was the third message that was brought out by the talk. So with this, I think we come to an end. I thank everybody for being here and enjoying this very interesting and exciting presentation. And this is the way the medicine is going to change. So thank you, sir, for providing us a glimpse into the future. And thank you.